conference throughout the end. We have a 30-minute session to conclude, and I don't think it's possible to have all these discussions without really understanding the fuel that burns the fire, and that is a little bit about the payer. A lot of these things are going to really revolve around the ability to actually provide an environment, a financial environment, to improve innovation. So we have two great speakers. Stefano had mentioned Charlene Frizzera. I think she's first. And she has a long history working for the Center for Medicare and Medicaid Services. She's served many different roles in that organization, including the acting director, the deputy director, and the chief operating officer. And she now has CF Health Advisors, where she works with different organizations in providing advice about how to deal with some of the change that needs to happen in the government and predicting future trends. So, Charlene?
So I appreciate the worst usually is before lunch. I think the real worst is before alcohol. So I'll try to make this as interesting as I can, but quick. So we could spend a whole day talking about what we think is going to happen in the new disruption and the new, do you want me to go up here? Okay. In disrupting healthcare with the new administration. So I'll hit on three big issues. The first one is you hear all the time repeal and replace ACA. Talk a little bit about what that means and what I think you can look forward to. The second initiative that they're going to work hard on is increasing market competition. And then the third is going to be increasing patient responsibility. So let me start with replacing ACA. First of all, I ask people, so what do you think that means? Right? I mean, I don't even know if people understand what is ACA. They don't really understand a lot about what it is. So what I tell people, you don't have to know a lot about ACA. What you have to know is what are the things that aren't working that this administration has to fix anyway. They have to fix the exchanges. They're not working very well. They have to fix fee-for-service and expenditures under that. They have to fix some of the financing that happens. They have to decrease expenditure. So if you think about what they have to do, it's not so much this technical term repealing ACA. It's about fixing all the things that are broken in the system that they would have to do anyway. So I think when you think about repeal and replace, I wouldn't be worried about bundles or innovative ideas. This new administration is going to be more interested in ways that the market can partner with themselves, that the industry can partner with each other to do a better job at providing better health care. So I think in the Innovation Center, you know, for those of you who know what I'm talking about, Medicare, CMS has the Center for Medicare and Medicaid Innovation, and that's been the place where all of the alternative payment models have come through. There's a lot of discussion they're going to get rid of that center. They're not going to get rid of the center because that center is what's going to design all the new alternative payment models to help them drive better health care and reduce cost. It's also important that that center stay together for the MACRA, the new physician payment rules, because the physician payment rules give additional bonuses to physicians who belong in the APMs. So if you don't have a center that can create APMs, you can't do the MACRA legislation, which is not a part of ACA. So when people start talking about repealing ACA, think about MACRA, which is the new physician rules, which is not a part of that at all and cannot be repealed. So there's no alternative to go back to. So important to remember that those alternative payment models are going to continue, which is where bundling, ACOs, all of those models are still going to exist. And I think in that, you know, you should think about companies to partner with in that space to do things new, to do new things and do things a little bit differently. The key to those APM models and the key to the new the delivery systems they're going to design is really about partnering with other people to do a better job at taking care of patients. So in your space, I'll tell you a quick story about an orthopedic surgery group that we do some work with. And what they found is they're having incredible savings by doing what they call prehabilitation and post-habilitation for acute care. I heard a bunch of people mention it today. So companies like Purewell, there's a great company that's doing some really cool, innovative things, trying to figure out how do I do pre and post rehab that patients like and will continue to use. And I think we heard that a lot today, right? Patient engagement is really important to a lot of these tools and partnering. CMS says two things have to happen to change healthcare delivery systems. Physicians have to change and providers have to change behavior, and patients. So those are going to be the two keys to some of the changes you're going to see moving forward in the what I'll call the repeal and replace ACA space. So I would not worry about it as much as be aware that the market, that the health insurance exchanges are going to be a big issue for them, and reducing expenditures is going to be a huge part of this administration's change in what they're going to do. So they can't repeal any of the stuff in ACA that's saving a lot of money. So bundled payments is a great example since you're all familiar with it. CBO testified that bundled payments are going to save about $10 billion over 10 years. In order for them to repeal those, they have to replace it with something that's going to save more money. So just keep those little, sort of processy things on your head when you think about what kind of changes can happen. There's still a lot of rules in the government that have to be followed. So I think repeal and replace is really going to be more about fixing the things that aren't working. The second thing I want to talk about is market competition. So, it's a general philosophy for the Republicans, are generally more market-driven, and they like to let the market drive itself. So they're going to try to increase competition in that market. A great example is going to be in the drug space. So their proposals are to get drugs approved and available in the market a lot quicker than they have in the past. That's their answer to trying to fix some of the drug costs. Not what the Democrats would want to do, which would be put in more regulation and more government control. So you're going to see this administration doing more to increase market competition and less in government regulations. As a matter of fact, my friends at CMS are telling me they hope Donald Trump sticks to his statement that for every one reg you write, you have to get rid of 2. They are thrilled. They can't wait for that to happen. So again, keep that in mind when you're thinking about what they're going to do. They're going to try to lessen regulation but increase market competition. And then the last one we heard a lot about is personal responsibility. So the Republicans are very adamant that patients need to be more responsible for the cost and their plan of care. So a quick example is home health agencies, there's no copay for home health services. Well, their theory is, well, that just encourages more use for home health. So we've got to start making patients responsible and have some skin in the game for their health care delivery. You've heard things, they're going to encourage these health savings accounts, right? So actually just the other day I heard somebody on the Hill say they're actually talking about modeling, giving every American $500 and an HSA and making that a part of their health care benefit and taking away some of the benefits that are currently in the system. Now, I wouldn't run out and be worried about that, but it just shows you that they're really thinking a little bit differently about who bears the burden of paying for those costs, and they really do believe that patients need to be more responsible for their care. So you'll hear them talk about health savings accounts. You'll also hear them mentioning vouchers for Medicare. Again, that's not new, right? You've heard that from many Republican administrations. They just think that if you give people money and let them manage their care, there's going to be a better commitment on their part to do a better job, one, partnering with the right providers to direct their care and making it less costly. So ideas like doing a better job at getting healthier before you go into a hospital for an acute event, like a knee replacement, this idea would encourage patients to do that because they're in the end going to have to pay for a part of their health care. So the less it costs out of their pocket, the less it'll cost the healthcare system. And then the last thing, we didn't talk much about Medicaid today, but I'll just put on the table, it's going to be a big part of this administration's agenda. They're talking a lot about adding more flexibility in the Medicaid program. So I think, if you think about what's going to happen in Medicaid, their goal is to try to figure out how do we change the way it's currently financed. So currently, the state pays a percentage and the federal the federal government matches that with some percentage. That system is a little skewed, and there are some things that happen in that are way too much to discuss today. But the funding that makes that match is not really a very effective funding. So this administration is starting to say we've got to wipe that slate clean, and we have to think of a better way to make states accountable and make them put real money into the system. And number two, give them more flexibility to redesign those Medicaid systems in a way they think is better for their patients. We've tried block grants for 20 years. It never worked because in the end, the devil's in the details and states didn't really like it. But I will tell you what they did this time. They added an option for a block grant or a per capita payment. More states are now a little bit more interested in that idea that if you give me a per capita payment and let me manage it, that's a better option than just giving me some lump sum of money and expecting me to manage under that. So, I think in Medicaid, you're going to see financing. Remember that the per capita addition to the block grant will make that more interesting for more states. I even saw an article this morning that talked about, states that typically talked about no new taxes are actually talking more with this administration about raising taxes. So states like Texas, some of the real Republican states are actually having conversations around implementing new state taxes to pay for some of the healthcare services. The last thing I'll say about what's happening in the new space, I would say two things. One, you need to continue to partner with other people. So if you're not partnering with somebody or having discussions with somebody you've never talked to, you probably should find that person. I think somebody used Blockbuster as an example. So my advice to everybody who says change isn't happening and I don't have to worry about it and I can just keep rolling along, fee-for-service is always going to be here and pay me some money and I'll be fine. Don't be Blockbuster. I think don't sit around and say it's never going to happen, because I think today you've seen startups and heard from them. There are amazing things happening in this healthcare space. And I think if you sit back and ignore that, in the end, you're not going to exist. So, you know, people always say, well, how soon? I don't know. I think somebody said it today, which I thought was a great comment. We overestimate 2, we underestimate 10-year change. I think that's really important to keep in mind, that keep the 10-year change on your radar, and the right space is somewhere in between. So we will have change, there will be innovation. 10 years, I would say you're probably underestimating it. Short term, we're probably overestimating it. So please partner, find new ways to do business in the Medicare space. Remember that patient responsibility is going to be important, so the more you can do to engage patients, that's what they're really going to be interested in, and helping understand how patients and providers can work together to really create a better healthcare system than the one that exists today. Thank you. That was fast. Whew.
That was informative too. Thank you very much, Charlene. So the second speaker is Tom Barber. Tom knows many of you in the room. For those of you who don't know Tom, he's probably one of the more accomplished orthopedic surgeons that I've met in terms of being innovative and at the forefront of a lot of changes that are happening in the healthcare environment now. So Tom's an arthroplasty surgeon at Kaiser Permanente in Oakland, and he's done his own personal innovation through My Doctor Online, which is a mechanism by which patients can communicate with physicians. He definitely was on the forefront of that. He's served a lot of leadership positions with American Academy of Orthopedic Surgeons. He was the chair of the Board of Counselors and has served on many of the committees, including those on quality and leading registries. And so he's also very knowledgeable about registries, which is certainly something that is highly debated, but definitely an improvement in orthopedics and has been adopted globally. So Tom, please.
Thank you for the introduction. This is going to be kind of fun. I don't usually get a job to where I can be sort of a pundit and talk about what's going on without a lot of knowledge, but especially because Charlene has brought a lot of the points forward that I was going to talk about anyway, so this is going to be rather quick. But I bring to this 4 years of experience as the head of advocacy for the Academy of Orthopedic Surgery. And the reason I mention that is I think we've really worked together with Congress around some of the MACRA and MIPS things and changes that have occurred, as well as Obamacare and where it was going with that. So I'm very familiar with a lot of the political things that have revolved around all these changes in Obamacare and what the emotions are on Capitol Hill and in the executive branch about where things are going. I also know Tom Price very well, who's taking over HSS, and we've had a lot of conversations about CMMI and about MACRA and MIPS and other things, and so it's been quite an interesting time for me to sort of see these folks transition in new roles, and you know, also being sort of overseeing the PAC for the Academy of Orthopedic Surgery has been interesting too. A $3.5 million PAC. We can sort of see how the money influences the process. I'd be glad to talk to people over a few cocktails about that. But let's talk a little bit about what I sort of see in the Trump administration and where things are moving. I don't have all the answers. All I can do is tell you the best of my judgment, given the 4 years of experience and the people I've talked to as to where things are going. There are a few general themes that we're going to talk about really briefly, and they're similar to the things we just heard about. Really looking at Obamacare, what's going to happen with that, where it's going, what's going to happen to our value-based purchasing programs, Are the folks saying that they're dead are really right or not? I agree with you. I think that they're still going to be there. What's going to happen to MIPS and MACRA and how physicians are paid, and CMMI, which I think has been important, at least to orthopedic surgeons, with the CJR program and what that means. What happens with the healthcare savings accounts and Medicaid changes, and most importantly, how does that influence all this high-tech healthcare changes and all of the startups that we're doing? Is it going to downplay that? Is it going to make it a problem, or is it actually going to accelerate things? And I'll talk a little bit about that, about where we're going with that. First of all, with Obamacare, this is a sort of broad legislative initiatives that Trump is pushing. One of them is to repeal and replace Obamacare. I just bring it up as one of his major issues. And he keeps saying again and again it's going to completely repeal Obamacare. I agree we're not going to completely repeal Obamacare because there are a lot of things in there that we're going to need to maintain. I think the biggest thing here against a full repeal and replace immediately is the funding. And I think that's really the piece that not everybody realizes is there are taxes and costs embedded in the Obamacare program that if there was a full repeal immediately, that money would no longer be available to Congress to allow them to put in replacement products. Whatever that might be. And they need that money to be able to do things to cover the 20 million people in some way, in a different way, presumably, but they're going to need the money from the taxes and from the cost relief in order to put together a new program. And so they can't just repeal without having a replacement ready. It's really politically suicide to do that. So that means that they will probably institute some small changes initially that will allow them to politically claim that they've repealed Obamacare, but it won't be the major issues that we're talking about here. And then they're going to be looking for a replacement down the road. There are some things to increase competition that I think are being considered. I know Trump's talked a lot about sales of health insurance across state lines. I don't know how that's going to play with his Republican base because a lot of them are really going to be against that. Because they're states' rights proponents. Senator Alexander is an example in Tennessee, very strong states' rights advocate. It's going to be hard for them to give up from the states control over insurance. And so even though that's going to be a plan going forward, it's going to be a challenging political lift. There are other things like allowing individuals to fully deduct health insurance premiums that may be able to go through. That's going to be a fight on Capitol Hill, but that's going to be something that we're going to talk about. And that depends, again, on the funding. Because if there's a full repeal and they don't have the funding available, they can't do that. And they're going to review the basic options for Medicaid. Allowing individuals to use health savings accounts in a more robust fashion, that is absolutely going to be there, and that's going to be there across all income ranges. So you've even talked about it for Medicaid moving forward to allow everybody to contribute some percentage of their income towards a healthcare savings account and having more deductibles there. So that's probably going to happen, and requiring more price transparency from all healthcare providers. So that's going to be a big issue. Block grants to Medicaid, we heard about a little bit, and how they're changing that to be a per capita issue. And we're also looking at removing barriers to entering free markets for drug providers, which, again, you talked about. So unfortunately, we're repeating a lot of the things that we did. And also he's looking at enforcing the current immigration laws to help reduce costs of health care. How much that's going to work, it's up to all of us to decide. I'm not sure it's going to be a big success story. And he's going to install programs to grow the economy so that we don't have the same costs for Medicaid and for Children's Health Insurance Program. Again, those are long-term goals, and we're not going to get there very quickly. I'm going to skip through some of this. What about, let's go through each individual one here. Let's talk about value-based purchasing. What's going to happen with that? And I think that this is one area where the Republicans and the Democrats really agree. We need value-based purchasing because it's going to improve quality and reduce cost. The exact form of that is that question. And I do think that CMMI, the Center for Medicare Innovation, that was talked about earlier, will continue to be there. Tom Price has held hearings on Capitol Hill about the fact that he doesn't like CMMI because they've exceeded their authority and taken authority away from Congress and brought it to HSS. And I think that he doesn't like CMMI when you talk about it directly, but primarily because they've been putting in place mandatory models such as the CJR, as opposed to putting in voluntary models that you could move forward with in a value-based fashion. So I think there'll be some change in the type of models they do and whether they're mandatory or elective, or and you can choose to be in it. And I think that's fine. We'll move forward, and we'll probably see a lot more innovation in some different arenas than we've seen before. So they will continue to be there in value-based purchasing, and I wouldn't worry too much about that going away. MIPS and MACRA, I heard somebody talk earlier about MACRA going away. It's not going away. No way. This is the only program that I've ever seen where Democrats and Republicans actually came together and held hands and danced a little bit about it. I think that nobody liked all elements of MIPS and MACRA. There were a lot of physicians and others that were upset by many components of it, but it's not going to go away because it's a bipartisan collaborative effort to pay physicians differently. And it revolves a lot around value-based care. There will be some changes perhaps in how we do risk adjustment, a little more push from Tom Price to do more effective risk adjustment and other things, but these are going to be small tweaks around the edges. They are not going to be major changes in the programs, so don't look for those to go away. CMMI, we talked about a little bit. Innovation will still be there. Tom's not going to eliminate the agency, even though he's talked about eliminating that agency, because it's going to be a major source of how he puts new changes into Medicare. So there's no way he's going to eliminate this program. He's just going to change how it's going to come forward. Healthcare savings accounts are going to be a big deal, and I would imagine that there will be higher deductibles on a lot of products, everything from Medicare, home health you talked about, Medicaid. All of them will have consumer-based contributions that are there funded by healthcare savings accounts. And I'm going to skip over the Medicaid things. Tech changes, obviously Twitter's come up a little bit, and if you want to read Twitter, you can actually see what Trump is going to try to do, I guess. These are some of the things that he's said. The Affordable Care Act is no longer affordable, and it's lousy health care and things like that. You can see how he's positioning himself here. But what's going to be the effect on the tech sector, and particularly in healthcare? What's it going to do, and how do we sort of predict how the changes are coming on in the new administration? The first one is it's going to be more consumer-based. They're going to, I heard somebody earlier talk about the fact that there are no consumers in healthcare. That may well be true, but on the other hand, there is going to be an effort to try to engage patients to become consumers. So how does that work? The only way that works is if the patients are actually paying a percentage of the healthcare themselves. So there will be more of an effort to involve patients in payment for those services. So I think that's certain to come about. And how that's going to affect the tech services, I think that primarily what it's going to do is mean that patients and these new consumers are going to be more in tune with what things cost and how they can reduce those costs. So that's going to be important for the health sector to keep in mind. There will be more virtual care. Again, this is to decrease costs and to move forward in an arena that will have lower consumer participation in terms of dollars. So I think that's going to be important. The consumer is going to be really keeping track of how things work from a quality perspective, and they're wanting to know how the quality and cost balance out. And so that's going to be certainly areas where tech companies will be able to be involved going forward, especially in terms of managing the consumer expectations and the consumer costs. Lastly, there are a lot of competitive states for health insurance. I just put this up here so you can see that there are many states where there's not a competitive health insurance marketplace. And so in those that are very competitive, we will see even more of these changes moving forward. So the purple areas are going to be where I think the healthcare tech companies are going to want to focus, because there'll be a lot more competition moving forward in those arenas. That's about all I have to say. I mean, I could go on, but I know as much as you probably do from Twitter about what exactly Trump's going to propose. But I do think that you can see that a lot of things are going to stay the same, but I think that there is a bright future for healthcare tech moving forward, and it will continue to be there. So thank you all very much.
We get Tom and Charlene to come up, and so that I think that frames the. It's a very nice ending to our discussion. Are there questions from the audience? So one of the things that struck me, and sort of bringing it back to the idea of digital health and new innovations. I'm wondering. I've never no. I was going to say no. Nothing disrespectful, but I've never viewed CMMI or the government as being particularly innovative, and a lot of the innovations we've seen have come from the private sector. You may or may not agree with me, but what I'm wondering is now in the next 4 years, both of you from your different perspectives, what are the things that we need to do to better incorporate some of the innovation that's coming from the private industry into the government? So how is the government and CMMI and CMS going to perhaps adopt some of these new innovations?
So, and I don't know if Tom will agree with me, but first of all, I will say that CMS has done a ton of innovation. I mean, it may not be in the space you're in, but those innovation models, if you look at having worked there for 30 years, right? I mean, in this past 3-4 years, the change that they've made in the healthcare delivery system is unbelievable. I mean, for a government entity that has a lot of processes. So I think, if you look at all of the new models that they're encouraging, what's interesting is this innovation, though, they're not mandating the innovation. I mean, as Tom said earlier, the CMMI, the idea was to get the market and get the industry to partner to tell CMS these are better models, let's test them. And I think if you look at those models, they've tested from ACOs, which started out as a very structured pioneer ACO, to this last ACO model, which waives a ton of rules. It waives telemedicine. It waives the 3-day inpatient hospital stay. I think people aren't paying attention to them, right? If they're not directly involved in them, they're just not paying attention to them. And I think if you look at that innovation, if you look at the CMMI website and you look at the innovation that they've done over the past 4 years, I would say it's pretty incredible. The second thing I'll say is CMS cares about the patients they serve. So to the degree the private companies can help them deliver better health care to Medicare and Medicaid beneficiaries, that's what they care about. It's nice if it's good for the self-employed insurer, but that's not what they pay for, and that's not the constituent that they're trying to take care of. So you have to balance that some of those private industry innovations don't work for those particular populations. So I say to the degree there are good ones, that you have data and you can show that they actually will improve the health care of Medicare and Medicaid beneficiaries, they'll listen. If you don't have data about that population, it's a little bit harder to convince them that it's a good program for those populations in particular.
I'll give a little bit different perspective. I agree that CMS has been very innovative compared to itself, okay? Right. Not necessarily compared to the world. And let me just give that perspective because I look at CJR, the Center for Joint Replacement, and trying to change the way we do total joint replacement. Okay, now 10 years ago, there were articles written, and specifically from CMS, about how we needed to control the post-acute costs, in particular the difference in SNF admissions and the difference in home health care costs. And they said, oh, we're going to do something different and do a new model. That was 10 years ago. It took them 10 years to get to the point where they did a model. Okay, so that's number one, is it takes them an awfully long time to get through those kinds of changes. The second piece is, one of the things that Tom Price is going to bring to this is a simplification and more risk adjustment. Okay, so one of the things with CJR is it's a 1,000-page document on how to do a total joint program. It should be 100 pages at the most, because all of it is in-depth regulation on how to define how people do things, rather than giving you the freedom to define what is best for the patient and reduces costs the most. And so I think what we'll see is innovation that may not be that much faster, but it will be in a different vein. It'll be more risk adjusted and with less regulatory sidewalls that prohibit you from doing things in a different way.
Okay, just one more rebuttal. So I agree with you about simplification of the regs, and that I agree that this administration will try to make things easier. I don't agree about the post-acute care, only because while they haven't implemented the changes, for anybody who's never looked at the Impact Act, you should take a look at that. The whole purpose of that Impact Act, the reason people didn't pay attention to it is it was directed CMS to do studies, it directed MedPAC to provide information, so people don't pay attention to it because it didn't change reimbursement. That Impact Act, which they are implementing, they have started to collect the data they need to make those payment changes, and they've actually started to implement some of those changes. And I'll give you a couple on-site payments for LTACs. They're developing these quality measures that go across the post-acute care continuum so that every post-acute care provider, to the degree those measures apply to all of them, they will all have the same measure and they will get the same payment. So I agree, it isn't, they don't do it overnight, but you know, I still will say that they have done a better job at collecting the data they need to make good decisions. The hardest part for CMS is making irresponsible decisions without data. I mean, if you think about it, they provide health care to over 100 million people in this country. That's a very daunting responsibility. So to make changes too quickly is a little irresponsible, but I think they've done the best they can within that framework to either make some changes or put in place, hopefully for the next administration, the ability to make some of these bigger changes in the post-acute care space. So a little bit of a balance.
So I have a follow-up question, though, too, because, Tom, your understanding of joint registries and some of the case discussions that we had involve actually looking at data on the benefits of some of these different telehealth opportunities. And what would you, either of you, what perspective would you lend to that in terms of what we should be responsible for doing and then presenting to different payers in terms of making these improvements to encourage them to be able to continue funding them?
Yeah, you know, clearly I am a big proponent of registries and what happens with that. And I think that there are a couple of new innovations or new changes at the government level that will help us in terms of that. One is the 21st Century Cures Act really has a lot of things that will make things move forward more quickly, like through the FDA, but it will also free us from some of the constraints, if you will, of HIPAA and allowing us to create quality following, if you will, registries that will allow us to follow the quality of what we do. So I think that will make having a registry easier to put together and move forward. But I think the second piece is, as we've heard today, the registry that I helped design back in 2000 for total joints in Kaiser is now to the point where it's almost old-fashioned because it's not complete enough. And I don't mean that badly, because it's really good, but it needs to be more complete. And what do I mean by that? It needs the drug-based databases loaded down, which we're starting to get to. It means that we should have more PRO information available to us. There's lots. It should have more radiology information embedded within it. There are lots of things that could be pulled in, and I think that's where we're going to move forward, is when we really see how all of the data can be pulled together into a very meaningful way. And now with the government making that a little bit easier, I think we're going to be moving forward and making big changes by bringing that data together and making it easier to do.
Yeah, and I agree with everything Tom said, and I think the challenge for that is knowing what data you need. I mean, unfortunately, you can't retrospectively collect data, not some of it, right? So you have to start at some point and identify this is the data we need to collect moving forward, and I think that's what takes a little bit of time. I'll just, a quick analogy, when we were doing the Part D drug benefit, we sat in a room and we sat there for 2 days, and everybody had to put on the table every question we thought somebody was going to ask us. OMB, OIG, people, right? And that's how we designed our data collection. And because we couldn't answer those questions, we didn't collect the data from the very beginning, we wouldn't have been able to answer the question. So I think, I totally agree with you. I think the hard part, and I would encourage in whatever you do, thinking about the data that needs to be collected. And if you think about it, who's going to want, of all the people that are going to interact with that, what are people going to want to know? It's a good way to start on how to figure out what data you need to collect.
So I take it then the data is, which pertains to all these health systems. So we're likely to see a lot of engagement of this new technology through health systems that will trickle up rather than vice versa. Yep. That's great. Any other comments, questions? Any final comments from either of you? No? Well,
we should be optimistic about the future.
That's great.
It will.
Well, thank you very much. A round of applause, please. Stefano.
That was exceptional. So at the very beginning of all this, we actually had a group of volunteers who came on as my advisory board. I want to give them a quick shout out. Dr. Vale, of course, chairman of our department. Nina Kielsen, who was extremely helpful for me from Canaan Partners, but they had an offset today. She couldn't be here. Megan Conroy, who did come here and actually put us in touch with a number of our speakers. So great shout out to a lot of your support and work on this. Richard Capra, who is the president of the Academic Orthopedic Consortia, and he reached out to his peer group, and we got several attendees because of that. Thank you for that. Einor Sawyer, Director of Strategic Relations, and did a great job today with these sections. Charlene Frizzera, who you just spoke to, also gave me some advice and pointers. Mark Fransom, are you still here, Mark? From day one, supporting this effort, and thank you for that. Dan Kraft, who is super busy and came back briefly, and he also helpful, and Jordan Schlane, and Dr. Boyle, Dennis Boyle, whom I mentioned earlier, and Jeff Lowe, who isn't here. He's a Yale Harvard MBA pre-med student, remarkably integrated in this whole world, who's interviewing with us. Actually, hopefully he'll choose to come to us instead of some other program, but he's doing an interview at Columbia today, so he couldn't make it. But otherwise, thank you to all of you. And last shout out to Sarah, Michelle, Christina, Kathleen, Nick, and Aaron for all the work you did on the conference.
Okay, so Stefano has graciously asked me to close, and all I want to say is, wow, I really think, I love the passion all the way to the very end. The last two speakers, fantastic. We're better informed. I think all of us understand the landscape a little bit better, and now we've created a community for innovation. So last thing is, congratulations, Stefano.
Oh, thank you.
Well done. See you at version 2, DOC version 2. Stay tuned.
Great. We'll finish up conversation next door. We have a cocktail hour for everybody, and just to calm down, relax, and get ready for the rest of the week for those of you staying. Thank you.